Καλησπέρα σας. Να σας καλωσορίσω σε ακόμα ένα webinar που θα κάνουμε με τον Dr Eric Maisel. Να σας συστηθώ, εγώ είμαι η Dr Χριστίνα Σιμιτσή. Είμαι υπεύθυνη του προγράμματος ψυχολογίας στο Aegean College και είναι πάρα πολύ μεγάλη μου χαρά να προλογίσω σήμερα τον Dr Maisel. Να σας πω λίγα πράγματα για τον ίδιο. Είναι ένας πάρα πολύ γνωστός και εξέχων ψυχολόγος και ψυχοθεραπευτής. Και τα πάρα πολλά χρόνια από την καριέρα του έχει ασχοληθεί με το creative coaching. Έχει πάρα πολύ μεγάλο έργο και ψυχοθεραπευτικά και στο coaching. Είναι συνταξιοδοτημένος θεραπευτής οικογένειας και ζευγαριών. Έχει γράψει σε πάρα πολλά blogs και έχει κάνει αρκετές ομάδες θεραπευτικές. Και έχει ένα εξαιρετικό και πάρα πολύ σπουδαίο έργο συγγραφικό με πάνω από 50 βιβλία σε διάφορους τομείς, όπως και στο creative coaching και στην κριτική ψυχιατρική. Χαίρομαι πάρα πολύ που βρίσκομαι στο σεμινάριο αυτό, γιατί δεν θα σας κρύψω ότι και εγώ είμαι εκπαιδευόμενη στην συστημική ψυχοθεραπεία, που είναι πολύ κοντά στο οικογενειακό πλαίσιο που είναι ειδικός ο Dr. Maisel. Και πραγματικά χαίρομαι πάρα πολύ που θα τον ακούσουμε σήμερα μαζί μας, που είναι σήμερα μαζί μας και θα τον ακούσουμε. Dr. Maisel?
Yes, you ready for me?
Hello, Dr. Maisel. We're great to have you here with us. Please let me just give one more information in Greek to our audience. Όποιος θέλει από όσους μας παρακολουθούν να λαμβάνει τις ενημερώσεις του newsletter του Dr. Maisel και να πάρει βεβαίωση και για την παρακολούθηση του σεμιναρίου, παρακαλείτε να στείλετε το όνομά σας και το email σας στο helpdesk@aegeancollege.gr για να λάβετε τις βεβαιώσεις. Dr. Maisel, we're all eager to hear you.
Thank you. I wish I understood Greek, then I would know what was going on, but it's good to be in the dark. Good to be back with everyone. This is the 5th webinar in this series. In the first one, we looked at critiquing the psychiatric model. We looked at the idea that the current way of thinking about human troubles is flawed, and that the psychiatric model doesn't do a good job or a fair job of helping us understand what goes on with human beings. In the second webinar, we looked at humane alternatives to the psychiatric model, primarily ways of being with another person, sitting across from another person and being of help, kind of simple helping ideas. The third webinar, we looked at the idea of redesigning your mind, that is by using visualizations of a certain sort. You can not only change your thoughts, but the source of your thoughts. You can change the room that is your mind and redesign it and redecorate it, which is an interesting idea and I think an important idea. In the fourth webinar, we looked at my theory of personality, which is very simple but interesting, and that's that personality is made up of 3 parts. Original personality, that is how we come into the world. Formed personality, the person we become over time. And available personality, our remaining freedom to be the person we want to be and to make the changes that we want to make. In today's webinar, we're looking at the question of how to work with sad clients, but we're also tying together some themes from the other webinars and hopefully learning how to distinguish between this thing that is currently ubiquitously called depression and the more normal sounding ideas like sadness, despair, disappointment, etc. This is, I think, a particularly interesting moment to look at these questions because, as some of you may know, the DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association, which is what most helpers around the world use to diagnose and treat mental disorders, is coming out with a new revision in April. And they've added prolonged grief as a mental disorder, which is something they've been wanting to do for a long time. They've been wanting to sell the idea that if you are sad for too long, that's a mental disorder. And so they've arbitrarily set some numbers that you get to grieve for 1 year. Let's say your child dies. You get to grieve for 1 year, and if you grieve for 366 days, then suddenly that's a mental disorder. And if you're a child, let's say you're a child and your parents are killed, you get 6 months to grieve them, and after 180 days, that's a mental disorder. And I think that should help explain to you how flawed this system is and why this system exists to provide economic incentives for professional classes and pharmaceutical companies, but not provide really good relief for suffering human beings. So essentially what we're looking at today in this webinar is the shift in thinking, which I hope you can make. It's hard to do because you've been bombarded with the idea that clinical depression exists and that it's some kind of biological or medical problem, some undefined biological or medical problem. I'd like you to make the shift from believing that to believing that we're looking at human troubles, the same sorts of troubles that have been with us for tens of thousands of years, the same things that make us sad, whether it's hating our job or losing hope or doubting that the future will be good or feeling that life has become meaningless. These are things that have confronted us and affected us for all times, and they are not mental disorders, they're human challenges. So the headline is to get as clear as you can on the idea that despair, which many millions of people are feeling, is not a disease. Despair is not a disease. It's a state of being with lots of different kinds of causes. We may despair because we were harmed as children and we're not over those wounds yet. We may despair because some features of our original personality come together and make us a little sadder and wiser than the next person. There are all kinds of very natural reasons why we might despair. The current way that we deal with this despair is to throw chemicals at it, called antidepressants. But how is it legitimate to throw a chemical at your failing divorce, or your hating your job, or your sadness about the world, about what's going on in the world? I hope it doesn't feel legitimate that the helping profession's reaction to these kinds of human problems is to throw chemicals at it. These are the kinds of natural, everyday words we used to use to talk about our mood. We got sad, we were discouraged, we were unhappy. We had a case of the blues. Maybe we got demoralized because something happened. Maybe we were melancholic or dispirited. We always knew what these words meant. We weren't confused by them. They felt appropriate. And then they all got hijacked in about the 1950s when the first DSM came out, the first diagnostic manual came out. and started to sell us on the idea that there was this thing called clinical depression, this amorphous thing that could be not really defined. As you will remember from one of our previous talks, the DSM is silent on causes, has nothing to say about what causes clinical depression, and silent on treatment, has nothing to say what we ought to do for clinical depression. Of course, we know what they want us to do: chemicals, antidepressants. But without speaking to either causes or treatments, they were able to sell the idea that there was something called clinical depression, which kind of everybody now believes exists. It's very hard for two people to use words like sadness or despair or discouragement. We all want to say, I'm depressed. Oh, you're depressed. So I hope one of the takeaways, and this is a hard takeaway because the word depression is so built into our language now, one of the takeaways is, if you can, to try to stop using that word, because it's such a loaded, problematic word, depression, and to return to words like sadness, discouragement, unhappiness, despair, everyday words. So as I say, the only word we now use is depression, which is, of course, epidemic because despair is epidemic. People are despairing about what's going on in the world, what's going on in their own lives, losing hope for the planet, losing hope for their future. Of course, despair is epidemic. It's not depression that's epidemic, it's feeling bad, feeling sad. I think I just described in brief what happened, and that is that there was a paradigm shift from everyday language, roughly about 75 years ago, everyday language around grief, disappointment, despair, sadness, to this idea of clinical depression. So why do people continue to think that there is this thing called clinical depression isn't, when it's just a label for despair or sadness? Why do people think it exists? Well, everyone agrees. Everyone uses the language. Everyone uses the word despair. And it looks to be everywhere. If there's a media show on despair, it's going to be about depression. It's going to be about clinical depression and how it's epidemic and how many more people are suffering from it and what are the newest antidepressants, etc. People believe in this idea because the experts say so. And it's not just psychiatrists and psychologists, but everybody who's in the helping professions now sort of agrees to use this language around clinical depression. And you'll remember from a previous talk that it should strike you as odd that somebody with only a master's degree in, let's say, counseling, no medical experience, very little psychological training, should be in a position to, so to speak, diagnose clinical depression, diagnose a mental disorder, a mental disease, a mental illness. How can somebody with no medical training diagnose a mental disease? But all those experts say they can. Every family therapist says, oh, I see the 6 or 8 symptoms of clinical depression, and it looks like you have clinical depression, and let me refer you to somebody who can prescribe antidepressants. And so people rather instantly, children too, children are sent down the same path of antidepressants. Number 4, people believe in this idea of clinical depression because it's written about and talked about everywhere. People themselves say they have it. oh, I'm depressed. I have clinical depression. I'm suffering from depression. And many people, in fact, most people like to believe that they've identified some problem. And so while they don't want to be depressed, they rather like having the label clinical depression to describe and define what's going on. Another reason people believe in depression is that there appear to be drugs for it. There must be this if there are drugs for it, there must be this illness. Similarly, since professionals say it's treatable, it therefore must be real. Why would you treat something that isn't real? It would sound strange to say I'm treating despair, but it sounds much more reasonable to say I'm treating clinical depression. There is the claim that there's all sorts of scientific evidence for it. It's not a true claim, but there is that claim. All kinds of studies purporting to say all kinds of things. There's the claim, or people think that there are medical tests for it when there aren't. There's the idea that there are observable brain changes between a, so to speak, normal person and a person with clinical depression. Of course, there are brain changes. If something happens and I grow sad, of course you'll see that on a brain scan. My brain will change. It will look one way when I'm happy and another way when I'm sad. That doesn't mean that the brain change caused the sadness. It's exactly the other way around. The sadness caused the brain change. But neuroscientists like to use the picture of brain change as proof that clinical depression exists, but it's not proof. Number 11, well, if it's not biological or medical, well, it at least must be psychological, right? Depression must be psychological. No. It can be that our belief system no longer holds. It can be that we don't have good reasons for living. That's not psychological, that's human. That's our human inability to keep purpose and meaning afloat. Likewise, people believe in depression because there are, so to speak, psychological tests for it. No, because those are really just self-reports that work linguistically. If I'm asked, am I depressed? I'll say I'm depressed, and then the psychological test will show that I'm depressed. Nothing real went on there. Well, but since people get better, doesn't it prove that something was going on? Well, yes, something was going on. You were in despair and then it passed. But that it passed is not proof that you had a medical problem. Likewise, so they say, well, if you don't get better, isn't that proof that you have a disease? No. It's just proof that the despair is still there, that it's still lingering, that you're still suffering. 15, well, if I can't cheer up, it must be a disease, right? No, because it may be powerfully, deeply embedded in you, this sadness. And 16, something must be going on. Of course, something must be going on, but to call it a medical issue is to put it in the wrong category. Just let this slide sit here for a second. Unhappiness is human, always has been, always will be, and we're in a period of increased unhappiness, aren't we? Between the pandemic and world politics and the state of the world, and maybe our individual challenges, we may be unhappier than ever, but unhappiness has always been human. So, what causes this sadness? Well, you know the answer. A million things. Could be childhood wounds. It could be stuck in a job you don't like. It could be stuck in a relationship you don't like. It could be brooding about the state of the world. Many, many kinds of things cause sadness. There is no reason to look for neural problems, neural transmitter problems. It's obvious that many kinds of things cause this sadness in human beings. And so in working with a person, a client, sitting across from someone, inquiring about what's going on, trying to learn about the person's sadness, we might begin to have an idea about the cause, or we might not. The person across from us, or we ourselves, may not know what exactly is causing our sadness. It may be lifelong. To repeat an idea from an earlier webinar, it may be a feature of our original personality. We may have come into the world already sad. Or some early failure to thrive may have given us a sadness coloration for all time. But we may not be able to identify that. So on the one hand, we may be able to identify the cause of our sadness. Maybe it's clear to us that it's our job that we don't like, which of course leads to a pretty obvious line of attack, namely new job. Or we may not know what exactly is causing our sadness, which means we're going to have to try to deal with it without knowing the cause. If our client does have an idea about what's causing her sadness, we listen, we inquire, and we try to tease out her ideas about what's making her sad. If she has no ideas, or if we have our own ideas, we announce our ideas. Not as a diagnosis, but as a question mark. For instance, wow, so you have a 60-hour-a-week job and a little child in daycare. Maybe you're overwhelmed. Maybe that's what's making you sad. What do you think? We use human-sounding language like that to announce our ideas about why our client might be despairing. Similarly, we just wonder aloud about possibilities. Could it be this? Could it be that? Could it be the other thing? Maybe something has changed recently. Maybe something in the world is getting you down. Just talking about possibilities. Number 4, in line with our movement away from the psychiatric model, we say to a client, you know, there's a difference between a so-called symptom like sleeplessness, or gaining weight, or losing weight, or fatigue, disorientation, these things that are used as symptoms to diagnose mental disorders and clinical depression specifically. So we say, well, those are the symptoms, those are results, but let's try to figure out the causes. Let's not focus so much on the sleeplessness or the fatigue, but let's try to figure out what's going on. Yes, we want to address the symptoms, of course we do, but more fundamentally, more primarily, what's going on? Is it lots of anxiety that's keeping you up? Have you lost hope? Let's try to figure out what's going on. And so in these ways, we examine our ideas about what's going on and our clients' ideas. We chat about them. we also feel it. We sit there with another person, we feel that heaviness, that weightiness, that sadness. This is a whole body, whole human experience. It's not something just in the head. It's life. So we feel it with our client, we think about it with our client, and then the two of us together begin to co-create solutions, which is just a fancy way of saying we try to dream up some things to try. And let's say we can't get at what's causing the sadness. Your client shakes her head, I don't know. I've been sad forever. I've been in this state for years and years and years. Can't get out of it, have no idea what's going on. Well, then we acknowledge that we don't know what's going on. We don't act like we do know. We don't act that by affixing a label like clinical depression, we've suddenly learned something or increased our understanding. We haven't increased our understanding one bit by attaching a label to that not knowing. If your client says, I have no idea why I'm so blue, and you say, oh, it's because you have clinical depression, that's an unfair reaction on your part to just add a label to her situation. What we say is, oh, we don't know what's going on. Let's try to be here with that not knowing. Let's breathe. Let's try to relax. This has been going on for a long time. No reason why we should come to an answer in the next split second. Let's take our time here, be patient, be human. And let's make some guesses, some hunches. And what would be some of the natural guesses? Something about childhood, right? Something about current relationships. Something about the dreams your client had and maybe those dreams not being realized. She had aspirations and hopes and they didn't come true. We have an understanding of the kinds of guesses and hunches we might make. And in line with those guesses and hunches, we would put some practices and activities on the table. For instance, let's say it comes up that your client has always wanted to write a novel, has started many of them and stopped very quickly, and that's always disappointed her and made her sad. Well, it's very reasonable to say, well, maybe this is the moment to work on a novel. And maybe that could be a daily practice, a 20-minute-a-day daily practice of you working on your novel. And maybe that will relieve some of your sadness to actually be doing one of those things that you've always felt would be meaningful to do. So we connect up the practices and the activities to our guesses and hunches, and we make offerings. It's an offering. What do you think about a 20-minute-a-day writing practice? Would that serve you? With a real question mark. We're not trying to sell it. We're just putting it on the table with a question mark. And fundamentally, we're angling toward an existential solution to the despair, because what we most want for our client is for hope to return. Sadness and despair are rooted in hopelessness, demoralization. And if a client can get some hope back, she will feel less sad. So we angle for hope, and we angle for the idea of possibility, that life has not foreclosed all possibility, that life is not at an end, that there's more life to come, more good life to come. And between us, we try to co-create hope, and we try to co-create things to try. And whether we can discern the causes or not, and I think I just explained how you would work if you know the causes and how you would work if you don't know the causes. But in either case, these are the ways we can be that have nothing to do with a medical solution. This is a human way for a helper to be kind, to be compassionate, to be thoughtful, to have ideas to share, to be comforting. Somebody who is in despair needs comforting. To be present, which is not easy when somebody is sitting there completely demoralized. We want to solve that. We want to do something. We want to write a prescription, give them a chemical. But we're not doing that. We're not writing a prescription. We're being present with another human being. And we have our own lived experiences. We have been sad. We've despaired. We may be sad right now. And so we come to the moment with our own lived experience, and we are our own living solution. We have tried things. Some have worked, some haven't worked, but they give us ideas for what to share with our clients as to what kinds of things might be tried. And primarily, we try to be of help, not to cure, not to problem solve, but to be of some help. So, what are we doing essentially? We're talking. That's what we helpers do. Psychiatrists do that extra thing of prescribing chemicals, but most helpers talk. And talking means all of these things. These are all ways we deal with a client's sadness. We listen. We say what's on our mind. We notice what's going on. We notice where a client stops or stalls, what a client doesn't want to speak about, what a client does want to speak about. We ask questions. To my mind, we also do a lot of interrupting because there are clients who will come to us and want to tell the same story they've told previous helpers a million times over. They want to tell their story because by telling their story, they're avoiding figuring out what's going on and doing the work that would be required to get out of despair. So I think we have to interrupt their story often. And that might sound like, can we stop a second? That sounded important. Can we stop a second? I find myself interrupting clients' narratives a lot because they want to run their tapes rather than do the work, and I want them to do the work for their sake. We're comforting. I believe that we make both suggestions and recommendations. I think it's wise to have resources out there different from a psychiatric referral, other kinds of resources that you can send folks to. I believe that we offer ideas, especially, so to speak, philosophical ideas about how a life can be lived. I find it very important to talk to clients about the difference between a purpose to life and their life purpose choices. That there's a fundamental shift to make there in the direction of making strong life purpose choices. I also chat a lot about the difference between finding meaning, which is a fruitless search, and making meaning, which is empowering and brings back hope. Personally, I find it important to assign homework. That is, that my client and I have a very clear sense of one thing or two things, or at most three things that she's trying during the week. And I believe it's important that if we're worried, if we're in doubt, if we need clarification, we ask questions. We don't act like we know until we do know. Let's look at some of these pointed questions that we might ask as we're sitting across from a sad client, somebody who's sort of sunk into the sofa across from us. For me, the most important question is this question, that is having a conversation with my client about what matters to her. And I want to aim her in the direction of her returning to the belief that she matters and that her efforts matter. Many, many human beings are not feeling like they matter or that their efforts matter. And that's the root cause of their despair. They feel ineffectual. They feel like they have no power in life. Nothing they do counts. You might call this existential coaching or existential therapy, but it's certainly existential in nature, and it's trying to help clients identify their life purposes, in the plural, the different things that are important to them. And I have many ways of talking about this with clients, including that what's important to a person shifts over time, and that's natural. And what was important to my client 10 years ago may not be what's important to her now. Her situation may have changed, her belief system may have changed, the world may have changed. The second a client can say, oh, this is important to me, some hope returns. That's why I think this is such an important question to ask. In a related way, I like to know what clients love because they have run out of love. If they're in despair, they're not really loving anything at this moment. They have what technically is called anhedonia, namely inability to experience pleasure. They're just not getting pleasure out of life. So this is a place to be with your client. What do you love? And if they say nothing, my next question is, what did you love when you were 5 or 6 or 7? And then when they go back in memory to 5 or 6 or 7, there will be loves then. I loved to read. I loved to draw. I loved walking with my grandfather through the forest. Just helping a client remember what she loved is valuable because that helps her understand what she could love again. When she reminds herself that she loved reading back then, that may open a door to her loving reading again. And this may sound small. Is a return to loving reading that important? Yes, because any love that you return to is going to lessen your sadness. Terrifically important question to ask. From my point of view, we're not just chatting about things, we're aiming in the direction of doing things. I need my client to be able to identify and articulate what she intends to do, what action she means to take to help herself get over her sadness. I'm very clear in working with clients that talking about this, even if we gain insight, isn't enough. And insight-oriented psychotherapy, therapists know that insight isn't enough, work has to follow. So this is a good telling question to ask clients after you've had the other kinds of conversations we've been having about identifying causes and trying to reinvigorate hope. Somewhere in the middle of a session, you begin to ask, well, okay, we've done some good work here talking about this now. What do you want to do in this coming week to support this conversation, to support the ideas we've been talking about? What action do you want to take? For me, I work with creative performing artists and have for 30 or 40 years. They have their dreams, their ambitions, their goals, their desires. And for me, I do a kind of balancing act between inviting them to do reality testing and dream upholding. I want them to still have dreams. I want them to still have the desire to get their novel written and published. But I also want them to be real about what's required if they want to have that done, that they're going to have to write so many words each day and tolerate the process and then tolerate the marketplace and everything else that must be tolerated. So for me, working with clients is a balancing act between identifying what real actions they must take while at the same time upholding their dreams. And first of all, getting their dreams on the table, having them articulate what they still have hopes for. Another kind of question is, you're hurting, you're sad, you're demoralized, you've been disappointed in life, you're despairing. All of that is a kind of pain, a kind of heaviness, a kind of hurt. What might heal that? Invite your client to try to grapple with this question. And the answers might range all over the place. It might be healing to spend a little more time with one's children in the park, in the playground. That might be healing. It might be healing to have a conversation with a distant relative that you haven't spoken with in a long time. We have lots of ideas about what might be healing, but we want to invite our client to try to answer this question. What might heal the hurt? You're announcing that there is a hurt, not a mental disorder. But you're announcing to your client, you know, you're hurting. This heaviness is in part from some wound. And what might heal that wound? For instance, I work a lot with survivors of authoritarian wounding, that is, adults who were bullied in childhood by an authoritarian father or mother. One of our healing strategies there is to physically get far away. That is, for many adult children of authoritarian parents, they must move across the country before they can really start to heal. If they're still in the same house or the same town, it's that much harder to heal. If they're still in the presence, in the proximity of their bullying parent, the bullying continues. So these are the kinds of ideas we put on the table. What might work? What might heal? Very often what's at the root of the sadness or the despair is some regret, some guilty feeling, something that your client did that she wishes she could undo. Maybe it's the thing she did while she was drinking alcoholically. Maybe it's the thing she said to her child that she wishes she could take back. Could be any sort of thing that she regrets. And you can ask about that. You can inquire about that. Are there regrets that you're holding on to, and what can we do about that? For some of those regrets, maybe you can mend that fence. Maybe you can go back to the person you wronged and try to make amends. For other regrets, there's nothing to be done about them except to try to surrender to the fact that they happened and peacefully forgive yourself, if that's possible. For many people, one of the roads out of despair is forgiveness, self-forgiveness. And of course, this is its own subject, a very big subject, the cognitive solution. but we want to invite clients to change the thoughts they're thinking that support their despair. Those thoughts that are supporting their despair, we want them to change them. If they're continually thinking, I have no chance, I have no hope, we want them to learn how to dispute those thoughts, say no, 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 I still have hope. I absolutely still have hope. I refuse to keep saying to myself, I have no hope. That's not good for me. So I think whether or not we are technically cognitive therapists or cognitive helpers, all of us are working with our clients' thoughts, and we want to help them change those thoughts. And for many of our clients, they need to be more of the activist they want to be. There may be something that's really disturbing them about their family situation or the world or their community, climate change, politics, whatever it is, and they may have talked themselves out of engaging with that activity. But that may be one of their life purposes that they want to put on the table again. So I think that this is one of those questions worth asking. Do you want to put yourself out there? Is there some fight worth fighting? If a client says, yes, wow, I really do want to do some activist writing because I'm outraged by this, that, or the other thing, she's going to have a big burst of energy come after that. She's going to feel uplifted in thinking that she gets to express her outrage on the page. And that's going to lift a portion of her despair because she's going to feel like she has more efficacy, that there's something she can do, just a small thing, but a real thing that she can do. And clients also want to be of service to other people. Our clients are humane people by and large. And so you might say to your client, you know, we want to help you, and you want to help you, but you know, you might help you by helping someone else. Maybe there's some volunteer work that you want to do. I know that you don't feel like you're up to volunteer work because you're so sad right at this moment, but you might discover that by helping another person, you feel less sad. So this is another kind of question you can ask. What help might you, the client, want to offer somebody else? And of course, the basic question that you're asking your client, because you have to enlist her in this process, is, what do you think might help to lift your despair? Please tell me all of your ideas, no matter how wild they are or strange they are, or whatever they are. Please, let's get all of your ideas on the table about what might help. So let me wind down in our last moments together, and I hope there are some questions, some things that are on your mind when we're done. If you'd like to be in touch with me, this is the way to be in touch. My email is free to use. You can visit my site, and I have lots of interesting information. And I wanted to share with you just some of the books I've done on this subject. If you'd like to read more about my thoughts on rethinking depression, these are among my books. I've done more than these, but these 6 books I think are useful. There is a book called Rethinking Depression, which spells out a complete existential plan for living. In the Van Gogh Blues, I look at existential sadness and creatives primarily. And if you are working with creative and performing artists, I think this is a valuable book for them to be in touch with, because it speaks to creatives in a way that most other books about depression don't. I've done a book called Humane Helping, which spells out a lot of the kinds of activities and strategies you can use in working with clients. And then the final three, the future of mental health is about the shifting paradigm away from the psychiatric model. And then the two books that are coming out in June that I recommend to you are called Critiquing the Psychiatric Model and Humane Alternatives to the Psychiatric Model. They both come out from Ethics International Press in June, and I recommend them to you. So thank you for listening. Let me just repeat the headline. I'm trying to move people away from the idea that there is such a thing as a medically related clinical disorder called clinical depression to the simple but true idea that lots of people are in despair. And despair can't be treated with chemicals. It has to be treated in other ways, primarily by helping people resume hoping, by having hope return. So thank you for listening, and I hope there are questions, and let me return the webinar to the hosts. Thank you.
Dr. Maisel, that was an amazing presentation. Thank you very much for this webinar. As I can see from the live chat, there are no questions. But actually, I have a question. You previously said that people with depression and despair, they believe that and they do not have nothing to love. And I just was thinking if they have also despair because they don't believe someone loves them.
Yes, they may well feel that they are unlovable or that no one can love them or has ever loved them. And that doesn't, just the sound of that makes us sad, doesn't it? And so I would just sit with that. If my client brought that up and said, I'm unlovable, nobody's ever loved me and nobody can love me, we would just have to sit with that huge feeling. I wouldn't argue. I wouldn't dispute it. I wouldn't try to dispute it. I would sit there with the client and be there. And then slowly try to find some way to shift that thought. And I probably would go in the cognitive direction of saying something like, you know, that's a thought. We don't know the truth of the matter, but we do know that you're thinking that thought a lot. So I wonder if we can work on a cognitive change solution and have you stop thinking that thought. So that's one of the directions I might go with a person who feels like nobody loves them or that they're not lovable, would be in the cognitive direction of trying to change their mind and have them think that thought less frequently.
Great, thank you. Thank you very much for the answer. It was an excellent webinar. Thank you very much for all the information you shared with us. Thank you. It was an honor for us to be with us. And I think we're ready to close the webinar and
Great.
To wish you all a great day.
Thank you so much.
Λοιπόν, ολοκληρώσαμε και το webinar με τον κύριο Maisel, με τον Dr. Maisel. Ευχαριστούμε πολύ που το παρακολουθήσατε. Επαναλαμβάνω ότι να στείλετε τα ονόματά σας και το mail σας στο helpdesk@aegeancollege.gr για να λάβετε και τις βεβαιώσεις παρακολούθησης. Καλή συνέχεια σε όλους σας. Εντάξει, τελειώσαμε.